In this session, we will go through the basic TEE examination. Recent ASA or SCA guidelines also focus on the basic echocardiographic training along with the advanced TEE training. The goal of basic TEE training is to enable anesthesiologists to use this powerful non-invasive technique for immediate assessment of cardiac and vascular structures and heart function. Anesthesiologists with advanced training can use TEE to its full diagnostic potential. The following is a recommended focused exam which does not include all cardiac structures, but is useful for introduction to basic echocardiography skills and understanding probe position. The technical skills related to echocardiographic data acquisition are ultrasound system adjustment and transducer manipulation. It is important to master the transducer manipulation as this is the key to good examination. Two important aspects are the probe position and the crystal position, and it is the combination of both that is needed for a comprehensive examination. The TEE probe has a pair of wheels similar to a gastroscope. The large wheel is used to flex the probe forward and backward. Forward flexion is anteflexion, whereas backward flexion is retroflexion. The small wheel can move the probe side to side. This video demonstrates the use of the large geared wheel first to anteflex and then retroflex the probe tip. Next, the small wheel is used to flex the probe tip left and right for fine-tuning adjustments. The probe is progressively advanced in the esophagus to identify different structures of the heart at different levels and assess their function. Probe position at the upper esophageal level will help to identify ascending aorta at 0 degrees and then at 90 degrees, and also the main pulmonary artery and its left and right branches. This view is helpful in identifying any aortic dissection, pulmonary embolism, and correct placement of PA catheter. This is the mid-esophageal view, and the crystal can be rotated to 0 degrees, 60 degrees, 90 degrees, and 130 degrees, and also to the patient's right or left for interrogation. The structures identified are the right and left ventricles and atria, and aortic, mitral, and tricuspid valves. This is the mid-esophageal four-chamber view where you can see the right and left atria and both ventricles. There are tricuspid and mitral valves seen in this view. Issues that can be investigated are the 1. ASD presence or absence, 2. Chamber enlargement, 3. Mitral valve disease and pathology, and 4. Tricuspid valve disease and pathology. This is the mid-esophageal two-chamber view showing the left atrial appendage, mitral valve, and left ventricular apex. Issues explored in this view include 1. LV systolic function, 2. LAA interrogation for clot or sluggish flow, and 3. LV apex pathology. The mid-esophageal long-axis view allows the echocardiographer to identify and measure 1. The LVOT 1 cm from the aortic valve, 2. Ascending aorta, 3. Aortic valve, 4. Mitral valve, and 5. LV chamber size and function. Issues that can be answered are 1. Aortic root pathology, 2. Aortic insufficiency, 3. Mitral valve insufficiency and pathology, and 4. LV chamber size and function. This set of images demonstrates the mid-esophageal aortic valve long axis view. Color flow Doppler is added to the view on the right and demonstrates severe backflow of blood into the left ventricular outflow tract in ventricular diastole. This is characteristic of aortic insufficiency. Based on factors such as the jet width and extent of jet into the left ventricle, this jet suggests severe aortic regurgitation. In this view, you are able to see the 1. Pulmonary valve, 2. Main pulmonary artery, 3. RV, 4. Tricuspid valve, and 5. Aortic valve. Issues that can be answered from this view are 1. Pulmonary artery and valve disease, 2. RV pathology, and 3. Aortic valve stenosis. The mid-esophageal bicaval view shows a number of important structures. 1. Right atrium, 2. Left atrium, 3. Superior vena cava, and 4. Interatrial septum. Issues that can be answered are 1. ASD, 2. Metastatic tumor, 3. Volume assessment from SVC, and 4. Guiding central or PA catheter placement. Further advancing the probe into the stomach gives transgastric images of the heart at 0 degrees and 90 degrees. You can see the 1. Right and left ventricles, 2. Mitral valve, 3. Aortic valve, and 4. Tricuspid valve. Issues that can be answered are 1. Hemodynamic assessment, 2. LV hypertrophy, 3. LV enlargement, 4. LV systolic function, both regional and global, 5. Mitral valve apparatus assessment, and 6. Cardiac output and stroke volume. It is important to remember that the left ventricle is bullet-shaped and may have different wall motion at differing levels. The LV is divided into 17 segments for assessment of wall motion. It is important to interrogate wall motion at the basal, mid-papillary, apical, and apical cap views in both long and short axis in order to understand and document the movement of all 17 segments. The transgastric basal short axis view of the left ventricle shows the basal walls of the left ventricle and also the mitral valve leaflets. Primarily, this view is used to interrogate basal left ventricular function. The mitral valve takes on a characteristic fish mouth appearance in this view. Color flow can be added to determine the location of a mitral regurgitation jet. The transgastric mid-papillary short axis view is visible at a 40 to 45 centimeter depth of probe insertion and a 0 degree multiplane angle. It shows the mid-walls of the left ventricle, the anterolateral and posteromedial papillary muscles, and part of the right ventricle as well. This view is particularly useful for assessment of volume status and ventricular wall motion. Volume status can be assessed by measuring the left ventricular end diastolic diameter. Wall motion is assessed by evaluating whether walls thicken and contract toward a central point. At the mid-papillary level, all the cardinal walls of the left ventricle can be evaluated at once. The transgastric long axis view can be attained by rotating the probe omniplane angle 90 to 120 degrees from a transgastric mid-papillary view. This view gives another view of the anterior and inferior LV walls. It also nicely shows the mitral valve papillary muscles and chordae in some instances. Most importantly, this view gives another view of the aortic valve, which can be used for Doppler interrogation and assessment of regurgitation or prosthetic valve integrity. This view is particularly helpful in patients with prosthetic valves, which often generate artifacts when viewed in the mid-esophageal long axis. In summary, understanding probe position and crystal orientation will allow you to conduct a comprehensive and systematic examination of all cardiac structures.